So it's a great honor for me to give a presentation about one of debatable subject, which is starting the management of dyslipidemia with combination therapy or uptitrated approach. Okay. So to understand why it's important subject, we should understand that the global burden of hypercholesterolemia all over the world, it's making it one of the highest mortality rate of cardiovascular diseases, especially in Middle East and in East of Asia, that appear in the orange color. Therefore, in the European Society of Cardiology of Hyperlipidemia, they make a stress on making grading according to the lipid level to put patients in very high risk group or high risk or moderate or low. And depending on this score, we can start drug therapy at which stage. And the other risk stratification was done by the American Heart Association or the American College of Cardiology to identify who patient with a hyperlipidemia and at the same time with a major cardiovascular disorders. And the risk enhancer, it's depend also on the level of LDL and the total cholesterol. But after one of the most interesting trial, which is the PISA study, it's a large landmark study, started in 2010, and it's a still ongoing study. By this study, they used the advanced imaging technique for identifying the effect and the impact of LDL on atherosclerosis. I prefer a pointer, but okay, no worry. As clear here in 11, it's the level of LDL, it's between 60 to 70, which means even at the low level of LDL, still patient can have subclinical atherosclerosis. And this make all guidelines to be more tight and intensive in reduction of LDL and the total cholesterol, and putting familial hyperlipidemia as a part of very high patient for atherosclerotic vascular disorders, and putting patient with LDL more than 190 in the high risk group. To start management with a drug therapy in such a group with a class 1A. So this make intensive reduction of LDL to be mandatory in primary and in secondary prevention for all patients with a very high risk score to be more than or equal 50% from the baseline or less than 55 milligram per deciliter. Even if the patient in the primary prevention needing for such reduction, and in high risk group, it needed to be less than 70, and moderate to be less than 100, and in the low risk to be less than 160. So what is the treatment of high cholesterol? It's divided into statin therapy and non-statin therapy. According to statin therapy, we have a potent statins like atorvastatin, rosuvastatin with a high dose. But the rest of non-statin therapy, most of them are a new therapy like ezetimibe, which affecting the cholesterol absorption, and biskinine inhibitors like ocazabint ethyl, and bile acid sequestrant, fibrate, and niacin. But the question here is how to personalize management for each patient to avoid a complication of cardiovascular disorders, to start with a combination therapy or to go up to titration monotherapy. So there are many trials was done on the statin combination with a non-statin therapy. And the most common is ACCORD trial. In ACCORD trial, we can see they used fenofibrate in adding to a statin, but it had no effect on cardiovascular events in comparison to monotherapy. while the most important trials was done on ezetimibe in combination with a statin, which showed a beneficial reduction in LDL and in cardiovascular disorders. Especially in CAESAR trial, it's on patient with aortic stenosis, and SHARP trial on patient with type 2 diabetes and CKD, and IMPROVE trial, it's one of the large ongoing trial still until 2029. Okay, so in each study, in comparison between the combined therapy of ezetimibe and statin, we can see how the reduction for all patients can reach up to 25.8 in LDL in comparison to monotherapy. And in the SHARP trial, they compare between the placebo or statin alone or statin in combination with ezetimibe and showed marked reduction in LDL. But when to add PCSK9 inhibitors? There are two main types, alirocumab and evolocumab, in the two common trials that discussing the importance on cardiovascular outcome. It's ADOCE trial and FOURIER trial, and the still IMPROVE IT and RACING trial. It's two large landmarking trials that discussing the outcome of statin, ezetimibe, and in IMPROVE trial, they have another group for PCSK9 inhibitors. They found that there is a marked reduction in LDL, but the result on cardiovascular outcome is still under research. And the reduction in this LDL can be reached to 1.1 millimole per liter in comparison to statin alone, which is such 0.6 millimole per liter. And one of the recent non-statin therapy is a bempedoic acid. It can be given in a single tablet with the ezetimibe and can make a reduction, especially in patients with a very high atherosclerotic cardiovascular disorders and in patients with heterozygous familial hyperlipidemia. But its cardiovascular outcome is still also under trial and will be ended by this year. Otherwise, another approach is the stepwise approach. And this approach is the favorable one for most of the recent guidelines. It depends on the increasing intensity of a statin, which by previous research, they identify that high intensity statin who can reduce LDL level more than or equal 50%, and moderate one between 30 to 50, and low one less than 30. Even after adding another drug therapy like ezetimibe and PCSK9, we can reach up to 85%. And the new guidelines of the European Society tried to use this approach in the clinical by starting at first putting a score for the patient and knowing if the patient is very high or moderate or low risk. And if the patient indicated for drug therapy, they go forward to start with the high intensity of the potent statin, and if we couldn't reach to the goal that would like to achieve an LDL, we can add ezetimibe and lastly PCSK9 inhibitors. This is another paper that published by the American College of Cardiology in 2022. In primary and secondary prevention, they recommended using some factors to enhance patient to be adherent to statin. So according to presence of the adverse side effect from statin, according to presence of special groups that indicated for the new therapy, we can shifting from the high intensity statin to statin with ezetimibe, PCSK9, or bempedoic acid. And the last two types are very specific for homozygous familial hyperlipidemia before LDL apheresis. And this is the two diagram of this paper that discussing on the left side patient at not very high risk atherosclerotic cardiovascular disorders, which means doesn't have any acute coronary syndrome or any another events. It's also recommended to start with a high intensity of a statin, and then there is three options to add ezetimibe or adding biskinine or bempedoic acid. And on the very high risk score patients, it's the same, but we can start with the statin and then go to triple therapy, not just two drugs. The Canadian Cardiovascular Society of Dyslipidemia guidelines also support the same idea, to start with a statin and go forward to the maximum intensity. And once the failure of maximum intensity of a statin to achieve the goal of LDL, we can add ezetimibe or biskinine. But the most interesting that they discussed in the patient with atherosclerotic cardiovascular disorders, the best is to make a combination between biskinine inhibitors and a high intensity statin. The only condition that will indicate for one of the new drugs for triglyceridemia, when the triglyceride can be between 135 up to 500. In this situation, it's better to adding the new drug of icosapent ethyl. In conclusion, the statin is still the cornerstone dyslipidemic drug for all dyslipidemic patients, and ezetimibe in combination with a statin have a beneficial effect over the high-intensity statin with the adverse side effect or intolerable patients. And having in mind the biskinine inhibitor to be in addition for patients at the very high risk for atherosclerotic cardiovascular disorders or familial hyperlipidemia. And in prioritizing for combination versus monotherapy, it's preferred to be tailored for each patient and after discussion with the patient with his physician. And the war of today is still a very hard battle because the new one doesn't prove itself and the old one doesn't go to the history yet. Thank you.